So if the diagnostic test final report is available at the time of coding, the coder should code any confirmed or definitive diagnosis that is documented on the test results. Any related signs and symptoms to that confirmed diagnosis would not be assigned. So a quick example would be, say a physician sends a patient to radiology for an MRI due to low back pain. The final report confirms degenerative disc disease of the L2 area. Coder could code that low back pain as the reason for visit, but for the first listed diagnosis code, they're going to pick up that degenerative disc disease of the L2 area. So that code is 722.52. They would not code the low back pain 724.2 as an additional diagnosis, since it's a symptom, thus it's related and integral to that degenerative disc disease, or otherwise known as DDD. When patients are receiving therapeutic services only during an encounter, sequence first the condition or the problem in the medical record to be chiefly responsible for that outpatient service. Other diagnoses, again, those chronic conditions may be reported additionally. An exception is for patients receiving chemotherapy, radiation therapy, or rehab, or rehabilitation. In these cases, the appropriate V code for the service is first listed, followed by the diagnosis or the problem for which the service is being performed. So an example would be the patient is admitted for chemotherapy for breast cancer, right side. In I-9, your first code is going to be V58.11 for that admission for chemotherapy, followed by the breast cancer code, 174.9. And then there's the codes for I-10, same thing. Same concept there. So when a physician sends a patient to have a diagnostic test done, lab work performed, physical or occupational therapy, the physician must provide a physician order with the test or the lab work or the therapy that is to be performed, along with the diagnosis for the reason for that test or lab or therapy on the order. If a diagnosis is not on the order, physicians should be asked to resubmit an order with a diagnosis. So an exception would be screening mammos, as patients can self-refer for a screening mammo. Therefore, a physician order would not be required, but it is optimal. So incidental findings on a test are never to be reported as the first listed diagnosis, and the code should only be coded as a secondary diagnosis when the incidental finding represents an acute or chronic condition or complication of a current condition. So an example, in this example, patient receives an MRI of the lumbar spine for low back pain. The findings are an old compression fracture and again are degenerative disc disease with disc space narrowing. The old compression fracture is considered incidental and it would not be reported as an additional code, as old fractures, unless they represent a complication or late effect and the documentation supports such, otherwise that old compression fracture is not going to be added. So preoperative and ambulatory surgery. Preoperative evaluations are routinely done for clearance to surgery for patients with associated comorbidities or other chronic conditions. When coding these visits, the V code to describe the pre-op exam is always sequenced as a first listed diagnosis, followed by the diagnostic reason for the procedure or surgery that's being performed. Coder can assign any additional finding during the pre-op examination. On the for the ambulatory surgery, the first listed code is the reason for surgery. If the post-op diagnosis is different from the pre-op diagnosis on the operative report, at the time the diagnosis is confirmed, select the post-op diagnosis for coding since it's more definitive. So prenatal visits, you learn this in the pregnancy section. Just remember the V2 2.0 and the V2 2.1 cannot be used in combination with any other chapter. For I-9 is chapter 11, for I-10 is chapter 15, but the supervision for high risk of pregnancy, those can be used in combination with your I-9 and I-10 chapters.